Hey, good afternoon. Welcome. It is the THCB Gang, episode 18. It is July the 16th, about day 15,027 in lockdown and quarantine, where I'm in Northern California. We're about to head back into more lockdown. And I know that the pandemic is spreading across the South, Southern California, Arizona, Southeast, and should be a good time to discuss where we are in the world for the THCB Gang today. I'm Matthew Holt, your host, THCB founder and publisher, and we've got a great lineup today. We're going to go live with them in a second, but the people we have on, regulars, Kim Bellard and Vince Kuraitis. Kim is the former health plan executive who's been regular on THCB and used to edit Tincture Health. Vince, longtime health tech consultant from the wilds of Idaho. Becoming a regular now, Maggi Cary, CEO of the Cary Group Global, Washington, D.C. based, lots of government telehealth, telemedicine experience, and lots of other stuff, now doing a lot of clinician and physician coaching. And our guest today is a good old friend of mine, Suneel Ratan, who these days is hanging his hat at interoperability company Collective Medical, but that's a long and colorful past, which I'll tell you about in a second. So let's go live for the gang. And here we all are. And so let's start off around the horn. So I'll introduce you a bit more when we get into we start peppering you with questions about everything you know about. But let's go around the horn and start off asking people what they have seen over the last week. It's been yet another week of craziness. So Vince, let's start with you.
I'll flag a trend that I'm watching that I think is necessary. Will we see the depolitization of health policy regarding COVID at the national level? And there's indicators both ways there. I think I'll flag a couple of those, and I hope we can discuss these in a little bit more depth. For the first time, President Trump wore a mask. Okay, I think let's reward people or acknowledge when people do something right. And the other dynamic that I'm observing is that it's becoming much more acceptable for prior supporters of Trump to begin to criticize him. Hopefully that will have some impact. We'll see. I'll give you some examples. Yesterday's Washington Post, the traditionally conservative commentator George Will, scathing editorial, basically, we're headed in the wrong direction. The world is going to shit. Can I say that? Is this a PG-rated program?
Well, I don't know. My wife was saying something similar to the kids.
Okay, so you can edit that. You can edit that out if you need to, Matthew. In today's,
you can't edit a live show, Vince.
Maybe it's too late. All right. Maybe the FCC will be down on you.
All right. Well, I'll send the bill to you.
Another Washington Post editorial today, the governor of Maryland pointed a really interesting story. The dynamics are there's never been an airplane that has flown from Seoul, Korea, and has landed at Baltimore Airport until his wife requested from the Korean government testing equipment to be delivered to Maryland. And he writes about it, and he's highly critical of the whole Trump administration. So those are some, and then recently there's been also editorials in the Wall Street Journal. The trend again is, will we see the rationalization of policy? On the other side, since I'm trained as a lawyer and there's always two sides to an argument, what the hell is the governor of Georgia doing, saying, you cannot pass local ordinances requiring masks? Oh my God, what an idiot. And finally, I think the other trend I'll point out is this data formerly going from the hospitals to CDC in Atlanta and now going directly to HHS, and data previously, which has been public, is no longer public. What the hell is that all about? But we've got to see a rational depolitization of policy before we're going to get out of this hole. Thank you for the chance to be on my soapbox.
You may be on there for quite a while if you're expecting, if you're going to be on there until we get depoliticized. Maggie, come off mute and tell us what you think. Maggie, come off mute. All right, Maggie, don't come off mute.
I do. Sorry. So I second everything Vince has said, and especially the whole commercialization of data and controlling the data, because then you can say, look, we don't have any new cases. Our rate's gone down. We're not testing, and so therefore it's better. And the other thing that just really beep me off is this whole idea of McKinsey and Company doing the work, having several consultants doing the work, an entire team of high-priced consultants, as is said, to do the work of one person who was at VA. She was acting assistant undersecretary of the Department of VA, and they're making 100 million and counting. And this honks me off because this is I worked in the federal government, both under Clinton and HHS with Donna Shalala as a political, and then separately not associated with that in VA as a career person. And this just breaks, and I've been on both sides of letting and applying for contracts, and this breaks every rule. This was a sole source contract, and it's 100 million. I mean, there are limits. You can do some, but so again, sorry, this just really, as you can tell, beat me off.
You can say piss me off on this show, that's fine. And frankly, not the first time McKinsey's done something like this, and there's been a lot of scandal around that company for many years. Kim, this week.
Well, I hope we'll come back to the data thing that both Vince and Maggie have talked about with HHS and CDC, but I'll talk about the attacks on public health officials that we've talked about on several shows have now escalated all the way to Dr. Fauci, where the White House has put a hit list on him and try to indicate that he's wrong on everything. And even Peter Navarro went a little bit too far for them, which is hard to do. But it just shows that we know they're trying to de-scientize this whole pandemic and put our heads in the sand about what's really going on and attacking the people that are trying to help us through it, which is totally distressing. Yeah,
I mean, it's quite remarkable that we're at the point where if you identified Southern California, Arizona, Texas, probably Georgia and Florida as separate states now, that they're the 5 worst quote unquote countries in the world, and there's some we're just nowhere out of the woods. Whereas if you look at New Zealand and Taiwan, and those places have had advantages over us in terms of being islands, but it's just hard to imagine that.
The press secretary today apparently said, we don't want science to get in the way of reopening schools. Like, no, that's exactly what you do want.
What?
Well, my kids were going to go to school on August 18th, and now it's not going to be till the middle of September, if then. So I'm looking forward to yet again being homeschool daddy, and I'm not very good at it. All right, I'll give you mine, and then we'll go to Suneel and dive in a bit on this. So my quick one is that the Inspector General of HHS today came out with a report. God knows how the Inspector General was allowed to do this, where Seema Verma, who had been paying millions of dollars to her, going back to sort of sole source contracts, corrupt your buddy, had been paying millions of dollars to consultants to help her with her own public image and getting her in vogue and what have you, was finally ruled to have been out of bounds. I don't think there were any consequences for her doing that, and she obviously fought back against it. But it's clear that that's a tawdry minor piece of corruption along the lines of her trying to claim all that jewelry she had was stolen from her car. Should be paid off by the taxpayer, including the $6,000 Ivanka Trump diamond pendant that she happened to have bought for some very strange reason, maybe to please daddy. But she's said a lot of stuff, and frankly has been the least qualified, lowest impact head of CMS that I can remember in my time in healthcare. And looking forward to some real professionals getting back in that job, fingers crossed, starting in January of next year. All right, with that, Suneel, I will introduce you and then ask you about your thoughts for what you've seen in recent weeks, and then we'll dive into a bit about you and your past. But Suneel Ratan's a guy I've known for a long time. These days you're hanging a hat at an interoperability company, Collective Medical. Tell us a bit about what they're up to these days. You're the general manager for California. Something to do with like the Eagles, I guess. I don't know if that's why they have a California management. But before that, you spent a bunch of time working in the Contra Costa community clinic system. And then before that was what was Born Health Hero, one of the very first remote monitoring companies. Became Robert Bosch and some big ventures. And then way before that, you were, I think, Times correspondent in Washington, D.C., if I want to think you were in your journalistic youth. I may have got some of that wrong, Suneel, but start off with anything I deliberately got wrong there to correct it, but start off with what you've seen this week, and then let's dive a bit into some of what you've been seeing, and we'll talk a bit more about some of these issues that came up. But first off, what do you see in the last week? Come off mute and tell me what you've seen in the last week or so.
Yeah, well, I can, we are, a commercial data aggregator, analytics, and care collaboration company. So that having been said, and I'm going to avoid overtly political comments given the nature of my role, but obviously some of the stuff we're hearing about data being diverted from CDC to HHS is concerning. The idea of National Guard troops being deployed to hospitals to do reporting is concerning. Yeah. I think the thing, I think in terms of what's been, I think is kind of top of mind, and it's just the pandemic itself. And I think it's coming down to the point where, one of the things we're doing is we can push real-time alerts and notifications into hospitals around high-risk individuals based on having largely aggregated data from other hospitals, and we can pump other kinds of data into hospital workflow. As we're able to source them. And, I think kind of the week for me is captured by an anecdote where we're working with one of our hospitals to integrate their COVID lab data. And they're kind of going like, what is the value of this data when the testing lags are now up to 7 to 12 days? You know what I mean? It's just kind of encapsulates where we are with respect to the pandemic in one anecdote, right? Where it's chaotic and it seems like every level of everything is kind of teetering, and it's concerning.
Because there's not enough fax machines.
Well, yeah, that's a whole, because we can automate a lot of those processes for the hospitals because, we capture their data in real time by their admission, discharge, and transfer feeds. So this is something we can rise to. But I want to avoid kind of overtly political statements. But when you hear about, previously public data, because truth, we need to have an accurate beat on what's really going on, right? To manage our own behavior in the public health.
Right. We lost Suneel there for a part, so let's dive into that in a bit more in a second. Vince and Kim, we've talked a fair bit about this. I want in a second we get Suneel back and make sure his audio is working properly to figure out, to hear a bit more about what collective medical does and to go back into the world. But, we've talked a lot about this, and I think I brought up some weeks ago the issue of that you could look at Germany, look at ICU bed availability across the whole of the country, and they were reporting it in, accurately, not a country which has got a ton of EMRs. We spent a lot of time, effort, and money, as we all know, putting in EMRs, and somehow the reporting, isn't working on the CDC level. But before we get there, there has been some suggestions, I think Saurabh Jha is on the show today, was one of them said that, the CDC is perhaps trying to do too much. And it's no longer just doing infectious disease, it's doing, it's looking at a bunch of other stuff as well. And maybe it's too unwieldy body. There were some, relatively poignant and accurate, I think, criticisms of the WHO, some of it sort of treading lightly on sort of delicate political people like China and elsewhere, and perhaps not again, being as focused as it should be and being kind of pure and apolitical. So, but what do you think we're seeing in terms of the overall nature of the sort of bypassing politicization of what have been typically, scientific only bodies, including basically, Fauci's role at National Institute for Allergies and Infectious Diseases, and also CDC as a whole. Put that in context for us.
I think the premise that they're using about why they outsource this data is that the CDC systems are antiquated and too slow. And I think that's probably true. I think across the government and across the healthcare system, the data systems are nowhere near what they need to be. But I think they're really using that as an excuse, to how to control the data. But, if we didn't have the underlying problem, it would be harder to argue that. So, I forget, a panelist a few weeks ago talked about in another country, they can pull up real-time data across the country from EMRs to detect where cases are going up and what's happening. And we can't even do that at a local level, much less a national level. So, until we get our basic infrastructure right, we're going to be subject to this kind of politicalization and manipulation of the data that is, not going to be helpful in any way.
So we, and by we, in this case, I mean the worldwide scientific community, not the U.S. Political milieu. We know how to contain this virus, and 40 plus countries, as I've referenced before, are doing a really good job at it. And it's not that hard. It's really blocking and tackling. We're not talking flea flicker plays here. It's getting people tested and getting the results back quickly so that people can quarantine, and so that contact tracing can then be done with those people once the results are back. I read a tweet this morning of a woman it was a NBC employee who was saying, I got tested for COVID, and that was 3 weeks ago. The results came back today. So you can't do contact tracing if the results are coming back 7 or 10 days later. And then the behavior of the public and U.S. values, where we value our right to be stupid as opposed to our right to be collectively safe and concerned about our fellow citizens. So people have been off going to bars and spreading this disease. It's just a national travesty to see that. I think you brought up the article, Kim, in the Atlantic, which really resonated with me, where the rest of the world is pitying the United States. And I think that's probably a very understandable way of looking at this. I kind of throw up my arms and just go, we know what to do. We're just not doing it.
Life, liberty, and the pursuit of stupidity, I think, is what it is. Although we're
that's a great motto.
Maggie, so I want to get one last sort of kick before, and then I really want to dive into to what Suneel's sort of day job and night job is, and you're still on mute, Maggie, so please come off. You've been in the government, outside the government. You talked about this system of this idea of the data systems in the government can't handle it. Plus, the scientists, the scientific sort of basis of is the CDC trying to do too much, and therefore, structurally ineffective. If you look at what happened with Ebola, looks like we did a semi-decent job a few years back. This is obviously a much tougher challenge. I mean, where do you think we are between we need to blow out the institution and start again versus it needs reform? It's like defunding the police, right? How gentle do we need to be versus how much we need to start again?
So the NIH is still the envy of many countries, and CDC has been. But if you think about the federal government has been consistently defunded over years, and so without the money, it's hard for them to do what they need to. And yes, their hiring practices, the contracting, all that's unwieldy. Although the guys in power now seem to just be awarding contracts to whomever they want, meaning they may not be able to do the job. I mean, I've got a whole bunch of examples of that. I think it's probably a reformation. I think that people, that's not good. We might be killing people like we did in England in the Reformation. Sorry. Sorry, a little bit.
Kind of a revolution without, burning a few people at the stake, right?
So I think the federal government could use with some tightening up of hiring and firing standards. However, I mean, it's complicated, and it's not like, having worked in public and private sectors, the federal government is unwieldy and moves like an ocean liner for a reason. And part of that reason is to be consistent, and is to be able to do boring things like aggregate statistics. CDC has had a lot of problems for several years. I have a person I went to medical school with, was a senior executive there, and they've had real problems with lots of leaders. I can tell you stories that would curl your hair, but I'm not going to. And the current guy is not a really good leader. He didn't believe in HIV/A. I mean, he was whatever his name is, Redfield. So I think that they have been hobbled by poor leadership. So the final answer to your question, I think we should keep the good, not throw out the baby with the bathwater, and go forward. It's not going to happen in this administration.
Right. I mean, that's been a lot of the issues, and we'll talk about this on the politics of this, is that essentially if you want an activist federal government to fix a bunch of stuff, it's clear we're not going to get that. You know, we can't like call an emergency vote of no confidence or whatever they were doing in the UK, or they tried that, it didn't work over there, but you can't just, you know, flip the switch. You have to wait on the timetable of and end of January, early February, March, even if it looks like it's going to be the landslide, which the polls are now indicating is probably going to be a long time from here. Suneel, let's dive a bit. I want to flip the piece a bit here, and so you described Collective Medical as kind of as a data aggregating, I call it interoperability company. You guys started more with going from emergency room to emergency room, figuring out who was perhaps on opiates and who was doctor shopping. But there's obviously a lot. Could you describe a little bit about the data feeds that you're getting and that you're available to put it into? And then I want to break this into your past with a conversation which we've raised on the gang a bunch of times, and I really want to get into a bit here, which is this whole idea of how do we actually manage patients who are either under COVID or have chronic conditions or both. So just quickly, can you describe sort of soup to nuts what Collective Medical is doing now?
I mean, let's look back a bit, because I started out by describing us as a commercial data aggregator only in reference to a previous comment. But that's sort of the least of what we do, to the degree that we were founded really to connect the dots within a fragmented and highly complex healthcare delivery non-system. And one of the pieces of what we do in terms of aggregating data and having fairly sophisticated analytics is having the ability to present back to that non-system community data, so that non-system can actually start to behave as a system, because the essence of really what we're trying to support is the idea that we can identify really high-risk people and then create a set of tools that are connective tissue between various IT systems to really promote better support for those individuals. So, some of the key use cases for us amid COVID are the ability to use our platform, which, primarily our primary data sources instruction fees from hospitals. And we have those from roughly over 1,000 hospitals in the United States, of the roughly 4,000 or 5,000. We also have access, based on encounters at hospitals on our network, to continuity of care document-based data from intermediaries such as Care Quality. And as a function of that, we're, and then by being able to source other data feeds from, organizations such as the Orange County Healthcare Agency or the Washington State Department of Health, or Marin Health in Marin County as an individual hospital system, we're able to then take those results and notify hospitals when somebody with a positive, pending, or negative result is showing up in their facility. So among other things, you can take the appropriate protective action when you know that somebody, pretty much on registration, that somebody's been tested somewhere else and that they have a positive result. So that's one critical use case. It's also then, can provide a whole range of ancillary benefits to public health positive is hitting a facility or in support of use. Did we lose me again? Am I back?
Yeah, so we lost you. We lost you about what you were saying about public health data came into a facility.
Yeah, so I apologize for that. Maybe I just need to back out and get on the phone, but we can put public health, we can put lab data into a facility. So a hospital, frontline providers in a hospital can take the appropriate protective response. And we can also alert other points of care, such as health plans, primary care providers, so they know that those patients need help. And we can also provide support for critical use cases around everything from, bed management in terms of the automation of data about what's going on in the hospitals and the status of those patients, as well as things like contact tracing. In terms of, also, obviously another thing we can do is support our health plan clients in particular, and health systems with risk, ACOs and other entities, in being the individuals who are high risk for COVID, so that they can, based on their hospital utilization and what that says about their underlying diagnostic characteristics, so that those plans can mobilize the appropriate response in terms of reaching out to those individuals and saying, you need to do this, this, and this, isolate yourself, quarantine, make sure they're protected. All
right. Well, I'll give you a chance to get off the audio and go onto your phone, as we're struggling a little bit to get you. But I want to, don't be too long, because I want to get in something that we've talked about on THCB Gang a lot, and I think is getting more and more current, which is, and this goes back to something that was raised last week on the THCB Girl Gang. I think, or was it the WAML we were calling it, which was raised by Jess DeMassa when she said, just look at what's going on in Teladoc stock and Livongo stock. And I happened to notice that Glenn Tillman, the CEO, the chairman of Livongo, was on Kramer's show the other night, and the stock was being pumped and all that kind of good stuff. But their message is changing slightly, right? So they're talking about no longer is it just chronic care management, but it's now what can you do regarding chronic care. The COVID-19 crisis is suggesting to employers and plans and maybe providers elsewhere that they shouldn't just be thinking about people with diabetes or people with congestive heart failure in terms of remote monitoring, because you now have the idea of doing remote monitoring and telehealth inside the hospital for PPE saving purposes, and also keeping people away from doing sort of more intense monitoring with virtual ICUs and that kind of stuff within the hospital facilities. But also this idea of, are you collectively going to be doing more monitoring more generally of these of all kinds of populations, especially vulnerable ones? And you may have noticed that in this last week, United Health Group, a small managed care organization based in Minneapolis, has came out with something that looks very like what Livongo is doing, but is now it's now a service which incorporates, coaching, blood glucose monitoring for people with diabetes, but also things like Fitbits to monitor their exercise, and integration into a general care plan as well. So I'm wondering, if you start seeing more and more of that activity, are we getting at the sort of the sea change that I've been talking about, or am I still being optimistic that we're starting to think about changing the whole of the healthcare system, or is it pretty much going to be sort of back to business as usual? So we've talked about this before. I wonder if anyone's opinions changed. Kim, let me go to you.
I don't think we're at a sea change yet. If anything, I'm trying to remember whose tweet it was, but they said that the trouble that our healthcare system is having now with financially is a sign of what would happen if we all did actually take care of ourselves. It's a system that's up on sick care and very expensive people. So the monitoring that I think we're seeing now is based on that, not on really keeping us healthy at the early levels. I think we're a long way to go there because there's not the financial mechanisms in place to really do that. Even health plans, because of the turnover that they experienced with their members, they can't really invest now for things that are going to be 5 or 10 years off because they probably won't have those members. And so until we get to a point when people in the system generally are getting paid, not just on outcomes, but on actually being healthy and never having to get to those outcomes, I don't know that you're going to get to the sea change.
On the other hand, just to push you a bit there, we talked a couple of weeks ago about North Carolina, where the Blues are now going to start paying doctors on a sort of more capitated basis, ACO type basis. Same announcement came out from Blue Cross of Massachusetts, basically doing the same sort of thing just this past week. I'm just I don't know, at some point, most of the money now is still fee for service, and that whole ACO thing is still a bit of a fantasy, but I'm just wondering if you're hearing enough about this now, and there's enough thoughts that we know what we've got.
I've run a health plan when capitation of PCPs was the norm, and most of the fights we had was, whether they were doing services that were in or outside the cap. It became a game about how much do you pay them, and how do they code stuff so it doesn't apply towards their cap. So people will figure out how to maximize their revenue in most systems that you can come up with, and the doctors are particularly smart about this. So. And again, as I said a couple of weeks ago, you can do whatever the hell you want to in primary care, and it's not going to really drive a dent in the curve. You really have to get at the hospitals and the specialty care and the pharma to really make a difference.
On that point, and I actually, Vince, Maggie, and Suneel, if you're back on with us, dive in on that on what Kim just said. It's worth noting that in the last week, you've had basically everybody, well, not CVS because they're already doing it, but you've had Walgreens, Walmart, and now Amazon all announced they're doing something in primary care, either for their own employees or for a collective population. And I thought Amazon's announcement was particularly interesting. They're doing a deal with Crossover Health, which is a group I've known for a long time, because Scott Shreve and Jay Parkinson, who were the sort of leaders there, were early on at Health 2.0 doing interesting stuff. And they brought kind of an online clinic and an offline clinic together. And now they're going to work with Amazon. And they also do have a lot of care coordination for trying to police what happens when people leave their primary care system, go to the rest of the system, which, as you said, Kim, is where they spend all the money. So, you know, maybe it's, again, early days. I'd argue that you're starting to see some of the pieces in place. But yes, Kim, you could argue this stuff happened in 1993.
What was most interesting about the Amazon announcement was that it wasn't from Haven.
So the most interesting thing, to be completely off topic for a second, is that I got quoted in a piece about Haven this morning on the information. I spoke with somebody, and there's another guy called Matthew Holt, who's a very rich venture private equity guy. And they said, Matthew, you know, I said some blow about how Haven wasn't doing anything, and it was fell apart and Sean Emerson. And I was quoted as Matthew Holt, the head of, you know, New Mountain Capital. I was going, wish I was as rich as that guy. It was like, I think they fixed it later and said some guy who runs a blog somewhere. But anyway, all right.
So, Matthew, I'd like to try and put a frame around your question. You know, if you look in the rear view mirror, the front door to the health system, or has traditionally been the primary care physician. That's the closest thing that I think we've had. And if you look out the windshield, at least in my opinion, it's not likely to be the way that it's been, the primary care physician, but I don't think that there is yet an heir apparent. And it could wind up being big tech companies. It could wind up being large multi-specialty groups, but it's you know, unlikely to be your individual family doctor. So, you know, scenario, we've talked about this before. What if Amazon were to acquire a large telehealth company? And, you know, think about the way today that Amazon is essentially, for many people, the digital front door to the shopping experience. I need a, you know, I need a widget. I need an ink for my printer. I need, I bought some seasoning the other day because I couldn't get it at my local grocery store. I got it from Amazon. But the idea here is that Amazon becomes the front door to the retail experience. Well, if they had a telehealth company, to me, it's not hard to imagine Amazon then being the front door to the healthcare experience. Not necessarily that they're going to sell you the care directly in the same way that they have thousands, and I think it's something like two-thirds of their sales, or it's a large number of their sales, comes through their distributors, who you could look at as competitors, but they have the control over the process. I think that my metaphor for what's happening, and to go to your broader question of will we go back to the old normal, what COVID has done is, you know, if you have a deck of hands, or rather a deck of cards metaphorically, you know, we've thrown them up in the air, and at the present moment, all those cards are in the air. How are they going to land? Probably a few of them land the way that they've been, but it's just really too early to tell, I think, where things ultimately are going to look like. But so, it is a time of great change, great disruption.
So Suneel, I want to hopefully we're back on with you, and you're clear. We'll see how we do. We'll come off mute and take a look. But I wanted to ask you, because you've got two areas of work you've done a lot in that I think would be very relevant here. So the first one is kind of Kim's point about, you know, how do we manage the rest of the process? Obviously, when Health Hero, later Bosch, was doing stuff with the VA, you know, one of the first companies to really do sort of significant quote unquote care management at home, or whatever you want to call it, or chronic care management. But and you've got, you know, some theory questions. Did it work then, and can it work now in our environment? And the other piece that I think is worth mentioning is you've done a lot of time working in the safety net clinics in Alameda and Contra Costa County. I can't remember which one you were in, but in the East Bay of the San Francisco Bay Area.
Yeah, Alameda.
And a lot of what we're discussing now, especially under COVID, but also with chronic conditions, it's about how do you manage and manage the care of and change the behavior of, work with populations who are, you know, trickier than we tend to think of as being the nice people working for Amazon or Google. So give me a sense about how you think both those things have played out, and how they might change.
Yeah, I mean, it's an interesting question. You know, to the degree that, you know, you're seeing You know, because I think where we ended up seeing our market in terms of that it was always going to be hard because you had to have the care management infrastructure. It was always going to be really hard in something like Medicare fee for service. You know, outside of an ACO relationship, and it's hard to see how a lot of the ACOs are getting to sufficient scale to then, you know, outside of your care mores that may be doing it, get to sufficient scale to then develop the infrastructure for those kinds of remote patient monitoring based interventions. I think it gets, you know, so a lot of times when you ask me these questions, Matthew, I've kind of come to the point in my career where I've spent so long on high risk populations that I don't really understand kind of more mainstream populations, even people who are kind of like, you know, say 40 or 50 years old who may have diabetes but aren't necessarily complex. So it's a sort of a joke that at this point I only understand populations with really complex needs. And so I think in the safety net population, kind of what I'm seeing is that it seems like it's getting some traction, particularly text message-based interventions. One of my colleagues, I have a former colleague who went off to a really cool company in Encino called Impulse Mobile. And she sent me a link that I skimmed this morning about how Inland Empire Health Plan deployed a text-based messaging intervention. You know, they got like 1.4 million members and they deployed this to about 100,000 of them who are high risk for COVID. And I thought that was super cool. But I think when you're talking about, you know, a lot of where I focus in my work is on the population that's designated for Medicaid and Medi-Cal health homes programs. You know, they're really high risk, high acuity folks. And there's a lot of homelessness, other kinds of unmet social needs, plus, you know, the unmet social need, plus a behavioral health issue, plus complex medical conditions. And it's just really hard, you know, seeing the technology being put to use at this point for those populations. So did that kind of get at the essence of what you were asking, Matthew?
Yeah. I mean, I guess so there's two things going on, right? One is can you move that? The healthcare system spends, or the country and the healthcare system spends a lot of time, effort, and money on those populations, right? Disproportionately very, very expensive people. And to a certain extent, I mean, if you're a 40 or 50-year-old, you know, I'll classify myself in that group, being generous with the ages. If you're in that group generation and you don't have any chronic condition, you're not costing that much. And even if you do have a chronic condition, many of them are manageable, and so long as you're not seeing outbreaks, you're not that expensive. But once you start tipping into the older or the much more vulnerable population, or is it the much sicker population, much more medically complex populations, you start spending a lot of money very quickly, and that's where that's
a huge point.
And that's a huge point, right? So I think the question is, maybe that's a special population you know a lot about, but it's a very important population, as you mentioned. That's what we've got to do something about.
Not to interrupt, Matthew, but, you know, we did learn at Health Hero that the interventions could be really effective, right? We did a 3-year, or we did there was a health affairs piece that was published, I think, in late 2011 around a demonstration project we started in the Pacific Northwest, you know, in 2006 through the first phase through 2006 through 2009, and we were taking down the gross cost of a population of pretty complex Medicare fee-for-service beneficiaries like by 25% gross. You know, and then you netted out the intervention, and the savings were still compelling, but you know, all of the issues remain, which is you need the care management infrastructure and you need ways to deploy stuff. Obviously, it's easier now because we don't have to do things like dedicated devices, and even older adults have things like Wi-Fi. But you know, you just run into a whole bunch of challenges, which is just scaling it and making it efficient, making it cost effective, you know, making it really the juice worth the squeeze. And I'm not clear, even as Medicare Advantage penetration rates climb towards 60%, that we've overcome a lot of that.
I spent 30 years in health plans, and the trick was always, you know, case managing, care managing the very expensive people. I mean, everybody knew it all along, and every program that was tested worked on those people. The trouble is keeping it only dedicated on those people and not to everybody else, spending the money on everybody else, and doing a good job of, you know, keeping it up with those people, because, you know, habits are hard to change. So it's, you know, there's no magic sauce here. People know how to take care of chronic people and deal with them. The trouble is applying the secret sauce to the right people on the, you know, for the right amount of time to make actual changes.
Yeah. I read an article
I think that
somewhere in the last week, I can't remember where, that a third of Medicare beneficiaries really are still not at the point where they're comfortable with telehealth visits. So my reaction, though, was to flip that around. 2/3 of the Medicare population are comfortable already with telecare visits. And over time, I don't see any reason that we can't can't continue to narrow that 1/3, and that I expect there will be tremendous spillover from the fact that telehealth has been so widely accepted over the last couple of months that it's going to diffuse through the entire population or most of the population over the next couple of years.
So I'd like to get on 2 points and ask Maggie and Suneel about them that Kim just raised. So one is sort of infrastructure. It was harder when you had to do dedicated devices, as Suneel said, when Health Hero was putting their little health buddies out in the population. And now most people have got stuff. And the other part of infrastructure is, data around that. And Suneel, you're in a company now, Collective Medical, which is sort of collecting a lot of that data. And there are a lot of people trying to do data aggregation and fire streams in and out of EMRs and all that kind of stuff. And the second one is kind of focus, Kim, and it seemed to be, yes, maybe you lose them from the health plan, but I mean, we're at the point now where there's enough interest in focusing on those very expensive people from Medicare Advantage plans, and there are only a few Medicare Advantage plans, and even if they lose some, they swap to somebody else, they'll get some other sick people back in. I mean, are we there yet again? So I'd love to hear you, Maggie and Suneel, both weigh in on this.
I think Maggie's on mute.
Yeah, but let me make sure I understand the question. That you're asking if you think that we're at a place where on the Medicare Advantage programs we'll look at caring for the complicated.
Well, I mean, anyway, I'm trying to think generally. The Kim's criticism is that number one is that it was you know what to do, but you can't do it at scale for a bunch of reasons. And I would say infrastructure and data are a bunch of those, but there are services and other things you need. And the other thing you said is you can't sort of, it's hard to continue the focus on those groups. And these programs kind of get dissipated. They either get too big or they lose focus on the individuals they're supposed to be looking after, or those people come in and out of the system or whatever. I'm wondering, have things changed enough? Because we're talking, we've been discussing primarily programs that were done in the 2000s, which were relatively successful, but didn't scale, didn't go anywhere, and there wasn't seemed the need for them. We're now at the point where the technology has moved on a long way. And obviously the infrastructure is there, and I think the focus is moving. We have fewer people who are paying, and perhaps more concentration on it. But maybe I'm delusional. So
let me just say some things to be provocative. There's a woman, I don't even know if she's still alive, Louise Russell at Rutgers, and she says that it's actually cheaper to not treat hypertensive and let everybody have their heart attacks and die, and then only treat their survivors. I'm not advocating that, but I think that there's and the cheapest, let smokers smoke, because then they die and they don't access pension plans or health care. So that was the Philip Morris study in Czechoslovakia or something around that. It was cheaper than smoke. Out of Sweden, I think. But I think that until we start rewarding the behaviors, i.e. with money, the behaviors we say we want, it's just not going to happen. It's, everything is about follow the money. Kaiser had an interesting program where they, what they did is they brought kind of these complicated older patients in for a day. And during that day, they were seen in groups by a dietitian. By this, they had 15 minutes or so with their doctor. They found it cut utilization dramatically, because for a lot of older people, the doctors are where they go to get succor, if you will, SUCCOR, to get help, to have somebody take care of them. And at the time, it was one of the few functioning parts of the country. And I think I think COVID has forced us, love the metaphor of the cards. I just think that's so cool. It's exactly, so thanks, Vince. Are we ready to do it? It all follow the money. It all depends on the money.
I'm not sure it all does follow money, because look at how many people don't want to wear masks. The science is pretty clear by now. They're not wearing masks. And, 5 years ago, it was vaccines. The science is very clear on vaccines, and you have this dedicated anti-vaccine. Until people start believing that their behavior makes a difference in their own health, in their long-term health, and other people's health, we're going to have these same problems. And when Suneel was talking before, I was thinking well, the good news, quote unquote, is that we're all slowly becoming complex health people. America has half or 2/3 of us have multiple chronic conditions. So we're slowly becoming a nation of people that, deserve these programs. And that's the wrong way to go. We don't want to drift into us all being very unhealthy so we can get managed better. We want to drift very quickly into actually having better health habits.
So Kim,
Well, but if I could add to that, right? Because I mean, okay, so at heart, I'm now a data wonk, right? Having worked for a data company in and around a data analytics company for 5 years, and I get to go through a lot of data, and a lot of what we do is we can kind of draw a laser beam to people who are really struggling and suffering in crisis. We can look at the overall patterns in our data, and we can pretty much see that there is a significant public health component to what's going on, right? The people that are ending up in that top 3 to 5% of the population are the people who are really struggling because of some sort of unmet social need in older adult isolation, housing, food insecurity, loneliness, behavioral health conditions. And so I think the conundrum we're wrestling with it without going too excessively global, but I think it is something we're grappling with now, both between the COVID pandemic and the George Floyd induced discussion around health equity, which is really about, we're allocating, on the one hand, we do need, the pandemic reveals that we do need to preserve a certain amount of infrastructure, right? Our hospitals are, relative to what we may be about to experience, are not overbuilt. The flip side of that is there's a lot of money sitting in the healthcare sector and a lot of other places in our society that kind of over time does need to maybe find a better place, because we do need to attend to things like the built environment and how we're doing things like education and job training and all that good stuff. How we're helping older adults not be lonely.
We talked about defund the police. We should really be talking about defund healthcare and really allocating a lot of that money towards public health and other social services so that we don't get in the situations we're in.
Maggie?
And I think a lot of the healthcare system is willing to have that conversation, right? Because at the end of the day, I work with frontline ED providers every day, and they really do not want to be on the business end of a bunch of people who are coming in repeatedly because of an unmet social need. It's not their business. That's not what they were trained for.
Right, but who is paying the bills? And when I say follow the money, follow where the payers are, right? Patients, it's become now a political statement to not wear a mask. And the other thing is, if you look at human behavior, it's sort of like a sunk cost in business. Once we start behaving some way, it's really hard to change that because our whole identity is wrapped up in that, right? And so the masks to me are a non-issue, but the other thing is we don't really have the leadership that's going to kind of back the science.
So Maggie, I want to ask you specifically, because your day job, right, is talking with people who behave in a particular way or hard to change, who tend to be doctors. So what do you do, and what do you do with them? What worked at Health Hero and other places that we've seen that worked, and is that scalable? I mean, or is it Kim's point that or your point, you just we're going to get what we get? So
I don't know if it's scalable, but I think.
Well, what works? Tell me what works first. Is it streaming? Is it?
I can tell you what works: individual behavior and team behavior. But I mostly work with CEOs and C-suite people, right? And one of the challenges they have sometimes is and I see this a lot, is they don't see the whole picture of things, and they don't. So one of the techniques is to get them to be in the position that somebody that they don't like, I mean, I'm being real simplistic, and say, so if you were in that, what would you feel? Or to take them through an exercise. And I think there's a reason people do things. And as healthcare providers or anybody, our job is to give them a better reason to do something that's for their health. So taking hypertensive medicines, people say, well, I'm going to take my hypertensive medicine. I don't feel anything. I can't get it up. I don't see any advantage. And so they don't take it. So I think there's a huge component of exercise, of education, but it's really about behavioral changes. A great book called Influence by Robert Cialdini, Cialdini, and he talks exactly about how you influence people. Those of us with a science background think it's obvious. I have friends who are PhD scientists who don't believe this, don't think it's a hoax.
Okay, but even if you can do it, can you scale it?
I don't know about that. I would ask the people here who have scaled things.
Suneel?
I think one of the reasons it's difficult to scale in my experience was simply because a lot of the reason, again, this is going back into the 2000s, right? The reason why our model worked with Health Buddy, because it really wasn't about the machine. It was about the degree to which the machine and kind of a very primordial machine intelligence was able to link a human and a person struggling with chronic conditions in a home to a care manager a local care manager, and that really reinforced the connection and made them feel cared about, and to a degree helped them accountable. And I think, it's been years since I caught up with Rishika Fernandapole at Eora Health, but I'm curious as to whether they've done it, right? Whether they've deployed this stuff because they have highly local interventions and whether it works. And to a degree, if you can make those kind of practice models work, then, maybe it's not about economies of scale, but it is about economies of scope, right? Where you can use data like ours to zero in real time about who's really struggling and then connect them to these kinds of interventions, and, both from a machine and human perspective to make it really go. And in limited populations, you can do some really fabulous things. I think, I'm going to walk a fine line here because health plans are our clients, but I think the underlying question is, given the way our system is constructed, are they really incentivized to save money on anything, right? Because a lot of MLR is passed through. I think that's going to be an ongoing kind of issue from just an incentive perspective.
Yeah, I
mean, you guys are way more. Go ahead.
Well, that's a macro question, right? Which if you could talk about overall healthcare costs and they get to keep their 15%, are they all incented? As Mark Cuban was tweeting about there, they're all incented to keep the overall pie going because they get a bigger slice of the pizza pie. But I mean, I'm still wondering, the point whether we can make this scale to the right people. So just to return to the Haven thing, which was in this art and the information today, there were two things going on at Haven apparently that didn't work. First one was they tried to build a sort of telehealth plus online plus offline primary care thing in Ohio. And they weren't allowed because they had to be super secretive. They couldn't publicize it properly, and they couldn't get people to join in. And at the same time, Amazon was building one of theirs, Amazon Cares, for their own employees in Seattle, and the people at Haven felt undercut, and eventually they got killed, and that was part of the reason why Gawande left. The other one was that they were doing kind of what you're suggesting, Suneel, which is they were trying to look into the data and figure out, were there ways that with all that claims data of the Chase employees, the Berkshire Hathaway employees, the Amazon employees, that they could, find some magic way to save money there. And part of the issue, I think, is that there aren't that many. I mean, there are expensive people, of course, working in any population. There's going to be expensive people in an Amazon or a Chase employee population. But a lot of the people that we're talking about, your medically complex folks who have got multiple chronic conditions and are homeless, they're not working at Chase Manhattan or a Berkshire Hathaway company. They're probably not working anywhere, and they're in a dual eligible program for Medicare, Medicaid, and we're not aiming in the right place with some of these tools. So I think again it's a question. It's a question very much my perspective that. If we're going to make a change in how we're going to sort of try to do things, we have to make a bigger, grandiose change in how we pay for things. And maybe it's back to Medicare Advantage for all, or Medicare for all, Bernie Sanders wise, but with some flipping or whatever. It seems to me that trying to get there via a small piece here and a small piece there is going to be tricky. But maybe there, at some point there will be enough in the market that maybe it'll matter. Kim seems to be much more cynical about this even than I am, which is worrying if I'm not the most cynical person on the line.
That's pretty scary, yeah.
Vince, Suneel, you got any closing comments on that? And then we're close to the end of time, so we'll have to do a wrap. But
yeah, I'm going to pick up on a couple of the comments that have been made and point out something that I think is missing in the dialogue. I read and scan very broadly, and I think one of the themes that's emerged today is the importance of the financial payment system. I certainly agree with what Dr. Maggi and Kim have been saying. And so, I saw a article from the American Hospital Association. They're going to lose collectively $300-something billion this year. United Health Plans, their stock bumped up this week earlier because people aren't going to the hospital. So what I don't see emerging, and I'm kind of scratching my head over it, is what kind of payment system would we like to see? What I didn't see in the American Hospital Association was we're going to lose $300 billion, and the implication was bail us out, feds. But they're not saying what would the system of payment for hospitals, what does it need to look like? And certainly the health plans aren't going to be incentivized to put on a tagline of, and we'd like to see the payment system change to, because frankly, what's happening today is in their financial interests. So let's keep an eye on that. What kind of a payment system would we like to have? Clearly fee for service, which is still fairly predominant, isn't it. But what does the future look like? I'm not hearing a lot of voices talking about that.
Well, I did tell you about now North Carolina and Massachusetts who started to talk
That
about
may be a good example. Maybe there's some local examples.
But it's not, again, but that's a small part of the money. And
it's a small part of it. Yeah, let's see it on a more national scale.
Absolutely. Maggie?
I'd like to see statistics for COVID and every other disease go back to where it's not political and get the National Guard out of science. Because the other thing is, remember with the National Guard, there are HIPAA violations.
We didn't bring up HIPAA so far today, but that's interesting. All right. So we're just a couple of minutes before we have to end. So I'm going to end the same way we always end, which is to ask people what they're think they're going to see in the next couple of, in the next week, next couple of weeks. And at some point I'm going to go back and do on the first, chunk of these and figure out whether anybody got any of this stuff right. But let me ask you all, what do you expect to see? What are you looking for? What are you hoping for? What do you expect to see in the next couple of weeks? So I'll start with you, Kim.
Well, what I'm dreading to see is we've seen the rise in cases to scary levels, and the tail of that is going to be deaths. And so I'm terrified to see what's going to happen to deaths in the next week or two.
Yeah, big concern. Vince.
I referenced the editorial from George Will, the conservative columnist in the Washington Post, whom I typically don't agree with, but I think I have to agree. Unfortunately, my view over the next couple of weeks is it's fairly pessimistic. I think things are going to get worse before they get better. We're not yet as a nation at the burning platform where we essentially say we've got to abandon the status quo, this burning platform, we got to get off of it. And it saddens me deeply to have to say that.
Maggie.
I'm going to follow Vince and say I think there's going to be more examples of corruption and coming out, whether it's contracts or getting people out of jail, or and my frustration is what can we do? And not only that, Congress. I mean, imagine how they're going to be written up in the history books, and is that not important for them or for their kids? So that's it.
Well, I've got a lot of pessimistic people here. Suneel, what are you expecting the next couple of weeks? What sort of shoots of activity or things do you expect to happen that you think will start changing things one way or the other?
Well, I think it's going to be really interesting to watch Congress negotiate this next stimulus package, because that obviously has, huge implications for downstream public health, right? Everything from how we're supporting the pandemic and public health response to how we're, supporting a population amid a shattered economy to make sure that, because I think what we're all really worried about is we look at the data, right? Because we look at our real-time hospital data every day, along with a lot of the diagnoses. It's like we've already seen that overdoses are on the rise, and we expect, there's just going to be a lot more people who are struggling with behavioral health and a lot of unmet needs. So I think I would expect that over the next 2 to 3 weeks, especially given the cliff we're at with unemployment insurance, is going to be a big focus of attention.
Yeah, I would say that my conclusion to build on that is that there's a moment here where we're now in July heading to August, right? This should be prime sort of kickoff of the campaign season for presidential election. It's totally weird this year because there's no conventions and Biden's in a basement and Trump's running around doing lunatic stuff in the creating super spreader events in Tulsa, Oklahoma, and God knows where else. Having said all that, what has been going on is that Biden and Bernie have kind of been getting together on the policy side, and you're starting to see the first sort of shoots of what are we going to have if there is, assuming the Democrats win, assuming the polls are right, assuming they stay where they are, assuming that Trump doesn't recover from his current malaise in those swing states, and that we end up with Biden in the White House, possibly a Democratic Senate, and certainly a Democratic House. A lot of the stuff that we talked about, which includes, fixing the infrastructure around CDC and public health reporting, it includes thinking about how to manage the healthcare system. It includes a lot of the stuff which goes into the healthcare system, as Suneel mentioned, such as dealing with housing and issues of equity and employment and this other stuff. We're going to have to do something pretty big. Now, as Ian Morrison, when he comes on the show, has said many times, it's great to say we're going to do stuff, but we haven't got the money. We just spent $3 trillion or $4 trillion or whatever $6 trillion or whatever we spent so far. But it's clear that we can't go on the way we've been going on, and all those things need to change dramatically, and they can't go on the way. And we need to have some kind of at least national level idea of what the next system looks like. So, I'm with you being pessimistic, everybody, and I know Maggie's sitting there saying, what can we do? But there is a conversation to be had, and we're all sort of part of it, of how do you do this better than the way it's been done before, and can we not just go back to normalcy? And so what I'm looking for over the next few weeks is that, yes, there's going to be more craziness, there's going to be more corruption, but I'm thinking I'm looking for some sensible policy proposals to come out of, whether it's Congress and Pelosi and, the House around, or it's the wannabe Biden administration, or what's going to happen next. I don't know. I mean, I don't know the answer, but I think we'll start seeing some stuff that could be worth debating about, because a lot of political commenters I'm talking to believe that Trump is done with it, actually doesn't care. He's kind of more or less gone, and that it's really thinking, that we're going to have to hit the ground running when it comes to November and then to January. So maybe I'm being optimistic. Maybe we'll get just craziness for the next 6 months and a lot more, sickness and breakouts of hotspots and deaths. But I'm hoping that there is some, not New Zealand level of sensibility, but at least something better than what we've got coming up in the US. All right, well, that was my rant to end this. And we're basically done for this edition of the THCB Gang. I want to thank my regulars, Kim Bellard, from formerly Tincture Health and now regular on THCB, Maggi Cary from the Cary Group Global. You can hire Maggie to sort out your difficult physicians if you're a health executive watching this. And Vince Kuraitis from Better Health Technologies in the Wilds of Idaho. I want to thank our special guest this week, Suneel Ratan, who's with Collective Medical Technologies, but done a lot of interesting stuff in his past. It's been a great conversation. This is Matthew Holt, founder of THCB, publisher and at Baltimore on Twitter, and host of the THCB Gang, saying that's the end of episode 18. We'll see you same time, same place next week, unless you're on the podcast, in which case it'll be available on Friday. That'll be nearly the last edition of July. And thanks for watching.